everyone. I hope this webinar is useful and interesting to you. I created this because, because we've undergone something in Oregon that is unique and I think relevant to a lot of people who would like to see SBIRT implemented in their state or maybe in their health system in a more widespread way. A disclaimer, I'm not a health policy expert, but I've been doing this long enough to where I think we can share some lessons learned that will be helpful to people. So, the facts, what happened? Well, if you're an SBIRT advocate and you think this should happen in primary care or medical settings, we know that this is difficult. So far, widespread implementation has remained elusive. This is not an easy thing to do in medical settings. But in Oregon, about 3 years ago, something started to happen as far as billing claims. All of a sudden, billing claims for SBIRT dramatically increased. And they have been dramatically increasing ever since for the last 3 years. And that increase correlated with what came from Oregon Medicaid. Oregon Medicaid created a statewide SBIRT performance metric. So there's two questions coming out of this presentation that I hope to answer. The first one really will have to be answered by you at the end, what you think. After listening and seeing what happened in Oregon, you'll have to decide, is it something that we could do in our own state, or maybe at least draw lessons from this and implement it in a health system performance metric. But the second question, hopefully I can answer, and that is what lessons can be learned from our experience, because there are lessons to be drawn. So, if you're tuning in to this webinar, you probably know what SBIRT is, but I put this definition up just to remind people that SBIRT is a public health approach. We're trying to embed this or integrate it, or some would say impose SBIRT on medical settings. But, you know, medicine is different than public health. Most of our clinics are designed to diagnose and treat medical complaints that patients come in with. They're not necessarily designed to implement public health strategies like preventative services. That's what SBIRT is. So it's just a reminder that why this is difficult in some respects is because we don't have a healthcare system yet that is designed to implement public health. So let's start out with a timeline. What happened in Oregon? Let's start in 2008. And at that point, like in most states, I don't think there was much SBIRT going on at all. That's based on billing data, anecdote. And as far as we know, as far as any kind of grant, 2008, we're the first ones in Oregon to get a federal grant to implement SBIRT. This was primarily a resident training. At that time, the Substance Abuse and Mental Health Services Administration thought that if we want to promulgate SBIRT, we got to train people, and that's true. So they put out money. We got a 5-year grant to train residents, internal medicine, family medicine, and they practice in about 7 clinics in the Portland area and 1 in Klamath Falls. We did not just train residents and then cross our fingers and hope that they would practice SBIRT. I refer to this workflow because this is the workflow that the Oregon Health Authority later kind of adopted as what they want to see in all primary care settings in Oregon that see Medicaid patients.
Hey, Jim.
I can't remember. Yeah.
Real quick, I'm sorry to interrupt you, but are you using a speakerphone? Because the audio does sound a little bit muddled now that we've started. I didn't know if you were on speakerphone or if you were connected a different way than you were earlier.
Well, I'm not, but I'm using headphones. I can switch out to another set. Hold on here.
Okay.
Is that any better?
Yeah, that sounds a little better. Thank you so much.
Sure. So as I was saying, this workflow is what we implemented because we thought a team-based approach to SBIRT would work better, be more sustainable, and this is what the Oregon Health Authority later adopted. So this workflow may look familiar to you. So in primary care, what a lot of clinics do is start out with just 2 questions for adults at check-in. So 1 question for alcohol, 1 question for drugs. And about, on average, maybe 70–75% of patients are negative on those questions, and they don't need to be bothered again for a whole year. And the other folks, when they're roomed by a medical assistant or someone else, that's when they would get the 10-item questionnaires that really do the work of identifying who's drinking too much or has drug use. Then when the clinician walks in, they score those screening tools, and if necessary, they respond with a brief intervention or referral to specialized treatment. So this is a 3-step workflow that we put in place, thinking that this would be more sustainable for our residents to participate in. And it's like a pipeline. So you screen people, you intervene if necessary, and then the last step, of course, which we all know, this is what counts, is it documented correctly? So we know that there's probably more things that actually occur than what's documented for. And this is important when you ever want to track how often something is happening in medical settings. The documentation step is very important. And the analogy for this is kind of a leaky pipeline. If we take a 3-step process to do this, that means there's 3 steps where each process can break down and maybe not get recorded or performed. So back to our timeline. So we're minding our own business with our little grant in Portland. In 2009, however, the available reimbursement codes for SBIRT are turned on by Oregon Medicaid, meaning that they are being made available for clinics that see Medicaid patients. If they want to get reimbursed for SBIRT, they can now use these codes. We're going to look at those codes in a little bit. And then the other thing that happened in Oregon was we kind of conglomerated our different public health agencies into one, and we call it all the Oregon Health Authority, which is essentially Oregon Medicaid, but since everything's wrapped up in there, it's called the Oregon Health Authority. In 2010, our Governor Kitzhaber was elected. He was a big healthcare reform advocate, and then the Affordable Care Act was passed nationwide. So those two things will be kind of synergized with what Oregon wants to do. And then the next year, like a lot of states at various times, Oregon was facing a huge shortfall in Medicaid budget, so almost $2 billion. When we face a shortfall in Medicaid, most of the time what we have to do is either cut patients from the insurance coverage, cut what we pay providers, or cut services. And no one likes to do that, but it produces immediate cost savings. Of course, what we like to do, if you want to improve health care, is to save money by actually doing long-term sustainable changes, improving care, reducing waste, aligning financial incentives for patient outcomes and performance outcomes, creating fiscal sustainability. Of course, that is more difficult to do because it is a long-term plan. You can't do immediate cost savings. So to do that, we were lucky. We had a legislature on board, we have a governor who wanted to do this, and we had a sympathetic administration at DHHS, and we got a waiver. The feds basically said, we will waive your $2 billion debt if you agree to transform how you deliver Medicaid in a way that ensures it will bend the cost curve down the road. And Oregon came up with a very elaborate plan to do that, and they did transform how they deliver Medicaid. And what we're going to focus on today in relation to SBIRT is these coordinated care organizations. CCOs are kind of like ACOs, you know, the agencies that basically contract with clinics who see Medicaid patients. But under this reform endeavor that Oregon did, they really are responsible for the full integration of physical, behavioral, oral health all into one budget. They're held accountable for social determinants, or at least are expected to address that. They have to have community people on their board. And then the last thing that we're going to focus on is the last line in yellow. They're responsible for health outcomes and receive incentives for quality. So now in Oregon, the agencies who manage Medicaid contracts with clinics are now going to be held accountable for health outcomes, and they're going to receive incentives, they're going to receive money if they show that they're improving the quality of their health care. And this is just a geographical map of the 16 CCOs in Oregon. They mostly go by county borders, but sometimes they overlap. As you can see here, there's 16 of them. Now, How do we hold them accountable for patient outcomes and quality? Well, they came up with 17 incentive measures. So a committee established by the Oregon Health Authority came up with these performance measures. SBIRT is one of them, and you may be wondering, well, how did we convince the Oregon Health Authority to include SBIRT as part of its incentive measures? And I asked that of our addictions and mental health agency at the time, and it just said basically that they asked for it, and it just kind of happened. So there wasn't, a lot of lobbying that happened. It wasn't a big effort. It just seemed like if the state is going to create at least 17 performance measures that are supposed to help bend the cost curve, it was just natural that SBIRT was going to be one of them. So SBIRT was not the focus, of course, of what Oregon was trying to do and how it reformed its Medicaid. It was just a very small part of a larger picture of Oregon's effort to try to bend the cost curve. So SBIRT is in place, which is great. However, I do want to point out that a lot of people say SBIRT is evidence-based, and part of it is, and that's why the Oregon Health Authority included SBIRT. But if we were to take a closer look at what part of SBIRT is evidence-based, and I ran this by a few researchers to get their thoughts, I think a quick thumbnail table would look like this. So there's 3 different populations that should get SBIRT, and they're separated based on their own screening tool, essentially. Each population should have their own screening tool. And then how we respond, we either respond with brief interventions or referral to treatment based on how severe their use is. And each of those can be, sorted out and investigated to see how effective it is if we do brief interventions or referrals to treatment. So as you can see, if adults and pregnant women who are deemed to have, there's enough research that shows that if we do brief interventions for risky or harmful alcohol use, yes, we can expect a reduction in use, self-reported use. But most of the other categories, we don't yet really have enough evidence, especially in the eyes of the United States Preventative Services Task Force, to say that this is evidence-based that we can reduce use through brief interventions or referral treatment. So we don't really have enough for adolescents. There's growing evidence, people say, that it's positive, but not enough to reach the threshold. If someone needs a referral for alcohol use or referral to treatment, we do know that if someone goes to treatment, there's good evidence that they can stop using, but the act of the referral, so the clinician or behavioral health specialist who refers a patient to specialized treatment, that referral is not evidence-based. That has not been studied enough to know if that actually does anything. And then for drug use, as you may know, the bad news is a lot of people have concluded now that brief interventions for risky or harmful drug use seem to show a null effect. So it's not that we don't have enough evidence. It appears that we do have enough evidence to know that it may not have an effect. So, when we say SBIRT is evidence-based, it's really part of SBIRT, and I think that's important to point out here. So back to our timeline. So in 2012, we have these incentive measures in place, but of course we need to define the incentive measures. The Oregon Health Authority begins its work of formulating the actual metrics. So what are we going to record for SBIRT? How are we going to know what clinics are doing and what should they do? So this ratio is what we're going to look at. And they already decided that they're going to start off with adults. So this will be Medicaid patients 18 and older, and they have decided that they will include drug and alcohol use. So going back to my table, we don't have really good evidence for SBIRT towards drug use, but they decided to include that. And they need to create a ratio, a metric. And this is what we're going to look at, because if you wanted to create a metric, or maybe you already have one in place, I think it's interesting how these are created. You probably have a denominator and a numerator, meaning in the denominator, who is eligible for SBIRT, and the Oregon Health Authority, as we saw, decided it's Medicaid patients, and they have to be 18 years or older, and we're going to do this in a calendar year. So there's your denominator. The numerator, well, SBIRT is an acronym that stands for 3 different items, so ideally we would like to know when the clinic screens for alcohol and drug use. We'd like to know when they do a brief intervention, and we'd like to know when they do a referral treatment. That makes sense. So we have a denominator. We have our numerator, the benchmark we'll talk about in a little bit, and that is, how high does the clinic have to reach and that ratio to be considered, they're performing well enough so the CCO gets their money. But first of all, we have to decide what data element are we going to use to collect this information. And this is my second disclaimer when I say I'm not an evaluation expert. But as far as I understand, one way to do this is claims data. There's advantages to that. They are commonly or widespreadly, I guess, used data elements if you want to record what happens in a clinic. Another way to do this is EHR reports, an electronic health record, meaning we just ask clinics to send in a report, maybe on a quarterly basis, just telling us, captured in your own field, in your EHR, how many folks were screened, how many people were eligible to screen, so forth. Another way to do it, less commonly used, I think, because most people have EHRs now, but you can randomly select charts and dive into them and see how often SBIRT was done. You can do surveys. S is standardized patients. If you can have actors who go in and then you interview them afterwards to see if they were asked about alcohol and drug use. That's a great way to measure this. Obviously, that's not practical on a statewide basis. Remember, there are, like in many states, hundreds of clinics around Oregon, and we don't have all the money in the world to do as robust tracking as we want. Then the last part would be triangulation, meaning you use more than one of these methods, and if both methods report the same level of activity, then you have a good idea that's probably what's going on. So what did the Oregon Health Authority decide to use? And they decided to use claims data. And I'm not sure why. I don't know if they went through each method and weighed the pros and cons to do this. Perhaps they went with claims data because it's kind of killing two birds with one stone. We want clinics to get reimbursed in general for SBIRT, and so hopefully they already use codes. So why not use the codes that they were used to track what SBIRT is going on? Perhaps that was rationale. It's not entirely irrational, but as we'll see, of course, there are drawbacks to billing codes. So back to our ratio, to our denominator. So if we're going to use billing codes and we look at our denominator, then we have to decide, well, what codes fit as a qualifying visit. And he came up with a lot. The most commonly used, evaluation and management code is 99213, and that is included in there in the office or other outpatient visits. That's what's most commonly used. But, home visits are covered to some extent, preventative medicine, so there's a lot of them, but I think most common is the 99213. So back to our ratio, visit codes that are formally listed at the Oregon Health Authority, those go into the denominator. Now, the numerator, we start with screening. What billing code does the Oregon Health Authority decide to use for that? Well, what's available? So we need a code for screen, codes for VI, codes for RT. Well, unfortunately, screening codes, as developed by the American Medical Association or otherwise, aren't really specific to alcohol and drug screening. The closest that the Oregon Health Authority could come up with is CPT 99420. And that's a Medicaid code or commercial. I only include Medicare here because some patients are dual eligible. Whoops. And so that is included in the incentive measure, but it's really the Medicaid codes that are most commonly used for this. So CPT 99420 is defined as administration and interpretation of a health risk assessment instrument. Well, that's fine. That encompasses alcohol and drug screening, but it isn't specific. The other thing about this is that it needs to be appended to the service. So if I bill a 99213 because someone comes in with a sore throat and they fill out a screening tool for alcohol or drug use, I need to do a modifier 25, and then I drop 99420. So already, by adopting this code, we're asking busy primary care clinicians to remember to use this code that they've probably never used before. This 99420 is not commonly used, but in Oregon it now is because of this incentive measure. One other drawback of the 99420, and I admit that I cannot find a better code. This is what we're stuck with. But because going back to the definition, it says health risk assessment, the problem is if clinics use this workflow where they ask a very brief question to everyone, and only people who are positive on that brief question then get the 10-item questionnaires, the audit for alcohol, the DAS for drugs. One question, that brief screen, is not really an assessment. You cannot bill a 99420 for that brief screen. And that's unfortunate because the Oregon Health Authority would really like to know, are we asking all our adult patients at least once a year, how many times in the last year have you had 4 or more drinks as a man on one occasion? I'm sorry, 5 or 4 if you're a woman. And then the drug question is, how many times in the last year have you used a recreational drug or a prescription drug for non-medical purposes? We can't capture that if we choose to use billing codes because those questions are so short, they don't really qualify as an assessment tool and would not pass an audit. So that means we can only use that code for the audit or DAS. So we have to wait till a patient is positive first on that brief screen, and then when they're roomed and they fill out the second screen, the full screen, then we can bill. Then we can bill the 99420, and then we get credit for, quote, doing SBIRT, unquote. So that's a drawback. We can't capture that brief screen. And by the way, the purpose of that brief screen is it's not really fair to ask all patients 10 nosy questions about alcohol use, 10 more questions about drug use, when the majority of patients are not necessarily drinking above low risk limits, and they don't necessarily use drugs in the last year. So it really makes sense from a patient perspective to start with that brief screen first, and then you ask the nosy questions and do the real assessment if they're at least positive on the first screen. However, we cannot apply the 99420 until that second screen, so that's one drawback. Another drawback is there's no word, no alcohol or drug word in that description. It's just general health risk assessment. So how do we know when a clinic bills 99420 if they screen someone for, hypertension or pancreatic cancer or something? I don't know. Instead of alcohol and drug use, we need to specify that code. So what the Oregon Health Authority did is not only do you have to use 99420, but back in 2013 when we used ICD-9 code, you have to use one of these diagnosis codes to specify what you screen for. That's understandable. However, that's yet another step. And the other drawback is, as you may know, ICD codes are really poorly suited to describe what we're trying to do in regards to SBIRT and primary care. We're not necessarily screening for alcoholism. We're screening for unhealthy alcohol use in general. Not everyone's an alcoholic, and as you know, the DSM-5 doesn't even use the word alcoholism anymore. But there are no, at the time, ICD-9 codes that described screening for unhealthy alcohol use. We didn't have that luxury. And for drugs, it's even worse. There's a lot of codes for drug abuse and other diagnoses, but not just drug use in general. So they did the best they could. They picked the 79.1 and 82.9. And so if we go back to our table here, you have to use one of these codes along with the CPT code to tell the Oregon Health Authority that, yes, we have screened a patient for alcohol and drug use. So not so simple, not so straightforward, but using the tools at hand that we do have in our healthcare system with billing reimbursement, this is the best at the time that we can do. So if we screen someone for audit or DAS, we bill the 99420, then we have to use one of those V codes. And if we do that, then we get credit finally for doing SBIRT. So back to our ratio, that S code is now, we have that in place. So that's our screening code. Next, brief interventions will be performed. We'd like to capture those. How often do they happen? Well, if we're stuck using claims data, what codes can we use to capture that? As you may know, there are some more specific codes when it comes to brief intervention. So the 99408, which is for Medicaid, and then down to the 9949, the only difference between those two is how long do you spend doing screening and brief intervention. So notice they don't separate out brief intervention. It's screening plus brief intervention. So the nice thing is these are specific for alcohol and drugs. So if someone screens positive on the AutoDAS and you do a brief intervention, just bill the 99408. However, there is an onerous requirement associated with this code, and it's not based on evidence. It was pulled from thin air, as far as I can tell, from CMS. They require that you spend at least 15 minutes doing this. So you have to spend at least 15 minutes giving a patient a piece of paper to fill out, which probably takes 10 seconds. They fill it out, which takes a minute and a half approximately, according to studies and the audit. And then you do a brief intervention. At that point, you need to spend, what, 11 and a half minutes or so on a brief intervention. And if that all adds up to 15 minutes, then you can use this code. That's a problem because there's no evidence that says you have to spend at least 10 minutes or something on a brief intervention to be effective towards someone's unhealthy alcohol or drug use. There's some studies that suggest even 3 minutes can be effective with adult alcohol use. Other studies show, 5 or 8 minutes. So this 15 minutes is bad because it's not based on evidence, and 2, it doesn't reflect the realities of a busy practice in the real world. No clinician, a medical clinician, has that kind of time spent with a patient. 15 minutes is what you get usually for a whole visit when a patient comes in with 2 or 3 medical complaints that you don't have time to get to, let alone try to squeeze in SBIRT. So these codes are rarely used because of that reason. The other problem is, and this points to the strange nature of billing codes in the reimbursement world, is you can't always get a straight answer when you have a question about who can use these codes and under what situations. For example, at the bottom there, the bottom bullet point, we were told by the SBIRT specialist at Oregon Health Authority a couple of years ago that it seems like 2 providers are necessary to bill this. 1 to do the EMN code and 1 to do this SBIRT code. Of course, that's ridiculous. We're not going to have a second clinician come in just to do this. So, big problems with this code. They're rarely used. We'll look at the data in a little bit, and you can see for yourself how infrequently these codes are used. They do exist, though. I like to point out this. There is a CPT code out there for tobacco cessation. If you want to talk to a patient and use motivational interviewing to help them quit smoking, for some reason, CMS or the AMA decided that you only need to spend 3 minutes to do that, and you can bill for a brief intervention. So why tobacco and not alcohol or drugs, I don't know. So back to our workflow here. Again, that brief screen at the waiting room, for folks to do that, not billable, but someone who's positive and they get screening to an exam room, that is billable. And if we do a brief intervention and we spend at least 15 minutes doing it, that is billable. However, there's even more drawbacks to the brief intervention code, and that is not everyone is allowed to do these codes. So only certain people are allowed to bill codes independently, as you may know, and these are the people. Oregon Medicaid is a little bit different than Medicare, but they're pretty similar. And this is a problem because there's a lot of people not on this list who are probably well qualified, better qualified than physicians to deliver SBIRT practices to patients. For example, maybe a clinical social worker who's just out of school but not yet licensed. They probably have much more background in performing brief interventions based on motivational interviewing than a physician, but they would not be allowed to bill this. How about licensed alcohol and drug counselors? Alcohol and drug is right in the title of their profession, yet they are not allowed to bill these codes according to Medicaid and Medicare. So this is a problem, and it's also a problem too because in my experience, and I do a lot of training with clinics, it's the physicians who are the people less likely to have a background in talking to patients about behavior change. They're less likely to be exposed to principles of motivational interviewing. They're less likely to have the time needed to perform a brief intervention with a patient compared to a behavioral health person, but yet they're the ones right out of the gate who are allowed, of course, to build these codes. So it's really topsy-turvy here, and that is a detriment to a clinic who may have a great workflow in place because they have a behavioral health specialist who takes over when a brief intervention needs to be done. But if that person is one of these approved people, then they can't bill for it, which means that clinic doesn't get credit for it under the metric, and that's a real problem. Now, there is a possible alternative to this problem of only certain people being approved to bill, and that is what's called incident to billing. Under this, basically anyone in the clinic, as long as the physician is present, a licensed physician, can bill these codes under their license. And that's great. And that means everyone. I mean, even the janitor, if they were properly trained in SBIRT, can bill for this under the license of a approved provider. However, like a lot of things in the reimbursement world, there are limitations. If you're a clinic associated with a hospital, I don't know why, but you're not allowed to do incident to. Medicare is not very clear incident to billing if you can do it with SBIRT. So the devil is in the details. So sometimes this is an alternative for clinics, other times it's not. Another drawback to using billing codes, if you want to use them to track how often SBIRT is done, is documentation. We can't just drop a number code and then expect that's good enough. We have to back up that code with language and a progress note. And some clinics have billing coders who will go over this language, and some clinics don't. But of course, if you're ever audited, this needs to be in place. And we consulted with our own billing code specialists, which is you, to determine what is necessary, what at a minimum we need to document to meet the 99408. If we were to bill it, because it takes 15 minutes, and this is what they came up with. So we have to say what screening tool was delivered, what the score was, how that score is related to a risk of related health problems, and then how do you document that you did motivational interviewing? Well, at a minimum, something like this. I gave my recommendation. We asked how ready the patient was on a scale, kind of explored why they weren't even less motivated, and discussed their motivation to change, and we agreed to follow up perhaps. And then the last part is, because this is a time-based code, you have to say total clinic time, administering and interpreting the screening form, plus a face-to-face brief intervention was greater than 15 minutes. So you have to say the stuff if you want to use these codes. And that's another burden because it's just not realistic to expect clinicians to remember this language, of course. One way around this is if you have a robust EHR, perhaps you have something like a smart phrase, which is a tool where you type in SBIRT and it populates your progress notes with this language, which then you can alter, and that's helpful. But not all clinicians use smart phrases, and they have to be built if you don't already have them in place. That means getting your IT people on board and testing it and spending time and money on creating these things. So the documentation burden is significant with billing codes. So I don't want to go further into the weeds of billing codes. I will say, though, at this point in 2013, when I was understanding this stuff, just as part of our own project, and seeing that there were health authorities going to use billing codes on a much more widespread basis to record this, I was just curious if CMS really knew what was going on, what the problems were associated with this. And I was not naive enough to think that a simple letter to them would make changes, but I decided to write one anyway, and I basically wrote up this problem with this 15-minute minimum, this problem with limiting people who can build these codes, and I was asking for clarity on incident to rules, so to know if clinics can use that or not. And I got signed by our dean of the School of Medicine at OHSU and the Oregon president of the Oregon Academy of Family Physicians. some of that addiction to mental health, hoping that those names would get the letter attention. And sure enough, a few months later, we got a reply. I didn't get the letter back, of course. We got sent to the dean of the med school. And this is what CMS said. They said, in response to the 15-minute minimum issue, well, we're not able to make any changes, and we'll take these things under consideration. So I was hoping for an explanation, maybe, of why they picked 15 minutes, or, you know, what the prospects are of lowering that, but they just kind of answered their 2 sentences. Next was, yes, there are a limited number of individuals who can bill for this. They just restated that, and anyone else does not have authorization to do it. So they just kind of reaffirmed that I was right. Yeah, only those people can do it. They didn't try to justify why, or why exclude other qualified people. They just kind of restated the issue. And then the last was, you know, can we use Incident 2? What are the rules around Medicare? Because there are dual eligible patients. And they said, well, that's easy because you cannot do SBIRT under an Incident 2 capacity with Medicare. Well, that's too bad, because if you Google Incident 2 in Medicare, there's lots of things you can use Incident 2 billing for. But for some reason, SBIRT, they decided to single out as something you cannot do Incident 2 for. So that's another strike against trying to use billing codes to accurately track SBIRT processes. SBIRT somehow is singled out for not being able to do this. So clinics will not have an option. So at this point, I moved on, and then I saw a report from, and I'm just sharing this with you because I thought it might be helpful. There's a report out from the White House Office of Drug Control Policy in 2014, and I read it because it mentioned SBIRT, and it even had a little paragraph dedicated just to SBIRT codes. And I thought it was interesting because there's a line in there that said that these codes provide uniformity in language to provide reliable nationwide data collection. And I thought, wow, if they only knew that billing codes really don't provide reliable nationwide data collection in terms of SBIRT. But I thought, wow, if they put in this report, maybe they would be engaged in trying to, you know, change this, especially since, you know, this is the White House office. They're under the executive branch, which the DHHS is under. I thought maybe since they're part of the same branch, you know, maybe that's a person with enough power who can communicate to CMS to change this. And so after a bunch of phone calls, I finally got a hold of Michael Botticelli. He's a nice guy. He's nice to talk on the phone. And I pointed this out to him, how we're really struggling with these billing code requirements in Oregon and how they're just not practical for recording this. And he sympathized with me and said, yeah, that's the problem. And that's it. Again, he's a nice guy, but he didn't seem to be ready, or that office wasn't ready to really take this on as something they wanted to fix. Next was someone told me that the CPT codes, even though they come from CMS, are created at the American Medical Association. And I looked there up, and they actually have a process for changing their codes, a code and change application. However, it's 27 pages long, and it would require someone above my pay grade to sign on to this and get this in motion. So this is like beyond something I can do, and I understand it would be a process that could last a couple of years. I don't know if anyone's undertaken this or not. Next was someone recommended, you know, this might be a legislative issue. You know, Senator Wyden is an Oregon senator, sits on the healthcare committee, whatever it's called, and I reached out to his chief of staff, I think it was, and we had a conversation that this took a long time to arrange. And that came at a bad time, she said, because that was in the middle of the website process when the healthcare exchange was rolling out and the websites weren't working, and it just wasn't likely that they were going to get enough bandwidth at CMS to address this concern in Oregon. So again, Senator Wyden's staff was very nice and friendly when I did get to talk to them, but nothing really came of that. The last bureaucracy that might have a chance is SAMHSA. You know, they're invested in trying to promulgating SBIRT and training people, and this is a barrier, and I think they know that from their grantees. And last I heard, they have made an effort, so they dedicated some staff time to reaching out to CMS to look into this, and that's all I've heard. That was like a year ago, and I offered to them that I'd be happy to go into any of those meetings to help explain the problem. But that's it. You know, I was like, I went above and beyond here what's expected of our project, but I was curious, and nothing changed, and all that came out of this really was a cartoon. Because a lot of people, when they talk about billing reimbursement, they refer to it as an Alice in Wonderland type reality, and it really is. And so I kind of made this funny cartoon, and this cartoon kind of represents the only concrete item that came out of my efforts to improve reimbursement issues. So if you want a copy of this cartoon, email me. I'd be happy to send it to you. So moving on. Those are the problems with the brief intervention codes. But we're stuck with them, and now we have our codes for screening. We have our codes for screening plus brief intervention with all their drawbacks. Next is referral to treatment codes. That's easy because there are none. There are no CPT codes, there are no billing codes that define or describe a referral to special-based treatment. And that's a real bummer because that means we can't track that in this performance metric. So if we were to simplify this, in our numerator, we have our screening code or screening only code, and then our 2 brief intervention codes, and then our denominator, these are the folks who are eligible for one of these codes to happen. So that's our ratio, and then next is, of course, is our benchmark. How high should be our benchmark? You know, if you see 10,000 patients in the denominator in a year, how many patients in the numerator need to get at least one of those billing codes? You know, what's the ratio? And this is my next disclaimer is, again, I'm not an evaluation expert, but I would imagine when you're trying to identify a performance benchmark rate, you probably start first with what is perfect implementation. And that, of course, is not reasonable to use as a benchmark, but you start there and you go down. And if you can, it's great to use something based in the literature and research to know what's a realistic performance rate. But it should be down for perfect, of course. So what is perfect? Well, this is the workflow that the Oregon Health Authority wants clinics to do. And if we can only start billing for SBIRT at this level, if you've seen the mouse there in the exam room, that means a perfect implementation rate would be, well, what % of our primary care patients are going to be positive on a brief screen? Meaning, how many primary care patients will likely have unhealthy alcohol use, they're drinking above low risk limits, or they've used drugs in the last year? We need to identify that because that would be our perfect rate, and then we would decide how far down to go from there. Because no workflow is done perfectly. There's lots of opportunities. Maybe the forms have not been photocopied and stocked. Maybe someone forgot to do their job. Maybe someone didn't enter in the data from the form. There's all sorts of things that go on. But perfectly, how many of our patients should get 99420 once a year? Well, we need to determine what the prevalence is in primary care. And so we want to know patients with unhealthy alcohol use in primary care. We want to know patients with drug use, they're part of this measure. And we want to know how many have both, because if you remember back to statistics class, if we want to know A or B, we add them together and we subtract C, and that's how we come up with prevalence. Well, that's not so easy because we don't have great studies to really give us these numbers. You may be familiar with the Manuel study that's commonly used now as far as alcohol prevalence and unhealthy alcohol use. 22% is a very commonly used number. We use that. Of course, some studies will be higher than that, some studies will be lower, but we need an average. That's a commonly used statistic for an average. The problem with that is it's almost 20 years old. It's for adults, which, as we'll see, eventually we include adolescents in this performance metric. It has a time period of 3 months. That doesn't correlate with a calendar year. but it's big. It's across several sites, and we use it. And it also measured drug prevalence, but for some reason it shows 6 months instead of 3. So there's already it's not the same. And the problem with these studies are, you know, the age varies, how big they are vary. They might be old. A lot of studies like to measure substance use disorders rather than drug use. If you search for prevalence of drug use in primary care patients, almost all the studies are about SUDs. And that's not what we want if we want to know how many of our patients use drugs. Because a lot of people use drugs without SUDs, and we want to identify them. So we don't have, if we want to do our equation where A plus B minus C, well, the state just decided, well, we're just going to take that 22%, and we're going to pick that as our perfect rate. So going back to the ratio, that's what they started with. And it's not great, of course, because it doesn't include drug use. It doesn't account for people who use both drugs and alcohol. But to their credit, the literature is a great resource right now to identify this, so they just went 22%. So if clinics were to do this perfectly, 22% of your patients on average would be filling out an audit or a DAST, because that's how many people at least have unhealthy alcohol use. And drug use is kind of split up into the 22%. Now we will lower it. So 22% is perfect. How much should we lower it? And this is where the Oregon Health Authority claims that they collaborated with us. Because I got a phone call a few years ago asking, you know, in our 5 or our 7 clinic little study, which we were tracking, they wanted to know, what was your highest performing clinic? At what rate did they perform SBIRT processes? And going back to our workflow here again is they want to know how many people qualify for that full screen. Well, just in terms of our own projects, since we only have 7 clinics at the time, this is not a widespread measure, we did not use billing codes to track SBIRT processes. We used EHR reports, and that was not easy. I can see why the state did not choose EHR reports, because it required us to work with 3 different medical systems to build tools in their own EMR systems to record each step of this process. That was not easy. People have different EHR softwares out there. It's not all one, and it took a lot of time to build these things. But it was a small project, and the good thing about using EHR reports is we got more specific data than billing codes could really provide. So when I was asked by the Oregon Health Authority how high did our best clinic perform, I looked at this chart, and there's our 4 highest performing charts. And as you can see, the green line, we were able to measure how often was that brief screen given at the front desk when indicated, how often was the auditor DAST given, the orange line, and then how often was the brief intervention time when indicated. So this is our data. And of course, there was probably more SBIRT going on in each clinic that was actually documented for. That's the nature of this sort of thing, but this is what we had. And what did I say? I said, well, I looked at our highest performing clinic, and I said, well, all 3 lines here seem to be around 60%. So I told the state, well, 60%, that is the rate in which our highest performing clinic performed SBIRT processes when indicated. And I said, thank you. And so they took that 60%, 0.6 times the perfect rate, and bingo, finally, we have our final ratio. So the benchmark, if we bill those codes in the numerator at least 13% of the time with all adult Medicaid patients who come in once a year, you will have considered meeting your benchmark, and the CCO gets the money, and everyone's happy. So that's the benchmark. However, you don't have to meet your benchmark to get your incentive money. CCOs that show that the clinics they contract with have at least improved, if not met their benchmark, but they've improved enough compared to previous year's baseline, then they also can get their incentive money. So you don't have to reach the benchmark. If you improve enough each year, you can still get your money. So we have our ratio in place, we have our benchmark in place. Back to our timeline, 2013 was when this performance metric went into place. So all primary care settings in Oregon who see Medicaid patients are now expected to do this. It's the CCOs they contract with who are actually held accountable. But the clinics, of course, are expected to do this. And then in 2014, they published the data from the year before. And then in 2015, they decided to include adolescents. So that denominator age was lowered from 18 to 12. And that meant that clinics now need to do this with adolescents. And that means a new screening tool, typically the craft, what people used. And it's kind of a different workflow. I won't go into that, but it's not an easy thing to just tack on to a performance metric on the ground in a busy clinic. It's a big change. They decided to lower the benchmark to 12% from 13 to account for adding adolescents into the metric, and I'm not sure why. It expands the denominator, of course, by including adolescents. But I'm not sure how they figured that. But they lowered it to 12%. The other thing that happened was, as you may remember, last year, ICD-10 codes went into effect. And here's yet another problem when you use billing codes to track something: is they can change because we don't create the billing code ourselves. So ICD-10 is in place, meaning our old codes, these are no longer used. Clinics can't use these anymore for yes to measure. We have to pick new ones, and that's a big change. So whatever automation processes clinics may have had to automatically drop these codes when necessary, they have to change that now. And then the Oregon Health Authority had to go look at the ICD-10 to see, well, what should we replace those codes with? What do we have to choose from? Oh, and this is my favorite graphic. You may know this V code for if someone has a burn because the water keeps caught on fire, you can build that. Very, very specific. But there is not a code for unhealthy alcohol use. If you type in alcohol and you search ICD-10, you come up with a lot of alcohol abuse things. But again, that's not the purpose of SBIRT. We're not trying diagnosing alcohol abuse. And as you may know, abuse is yet another word that the DSM-5 doesn't recognize. We have a spectrum now of substance use disorders. We don't use the words abuse or alcoholism. So that aside, this is not a good list that we can pick the code from, because a lot of people drink too much, but they don't necessarily have abuse or SUD, so we can't use those. Other codes that come up are alcohol dependence. Again, dependence is not a word used by the DSM-5 anymore. We're not necessarily screening for dependence, so we can't use any of those. There's another group called alcohol use unspecified, which may be promising, but when you look at them, all these associated disorders and things, and that is too specific. That's not what we're looking for. Alcoholic, there's other things, and they all don't work. What we need is just a code that says unhealthy alcohol use, but it's not available. It's not suiting our purposes. But the Oregon Health Authority had to pick something, and so what was these codes? Z13.9, Z13.9, and they don't really specify alcohol or drug use. At this point, I don't protest anymore because I know what they have to work with, and it's not much. So back to our table here. This is now the updated table with the ICD-10. You not only have to use the screening code when you screen someone, but you have to use one of these ICD-10 codes too. And when we lower the age from 18 to 12, this is what our workflow looks like now. If we use the craft for adolescents, we don't really give that in the waiting room because oftentimes adolescents come in with their parents, and if we can't assure confidentiality, it's not really worth screening them because the answers may not be honest. So we should only screen adolescents for substance use when we can assure confidentiality, and that's usually in the exam room when we can get them alone from their parents. So this is important because at a policy level, it may be very easy for people, who have the power to create performance metrics to just say, let's include adolescents. There's a lot of benefits to be gained from addressing the spirit of adolescents, and it shall be done. But on the ground, when this busy clinic gets a little notification that they're supposed to do this, then they have to look at their workflow. And they have to decide, well, whose responsibility is it to deliver the craft? When it will be done? how do you keep track of which adolescents should be screened? Because it's a once-a-year deal. And if it's not done at the front desk, that means the rooming person has to go to the EHR to see if someone's due for their craft. So little things like this are just complicate things. And yes, even though the evidence isn't there for adolescents or SBIRT yet, there's benefits still to doing this, and I agree with including adolescents. But again, it's not an easy thing for clinics to expect to do this. So finally, let's look at some data. So we have a ratio in place, and I created this line graph. On the y-axis are monthly counts of codes submitted to Oregon Medicaid per month. The x-axis is years, and then I put in a little marker there at 2009 because that's when these codes were available for use. They were turned on in Oregon Medicaid. And then I put a line in at 2013 because that's when the incentive measure went into effect. So what can we glean from this data here? I think one thing that we can conclude is simply by turning on the codes in your state, it may not necessarily lead to SBIRT. Those counts were less than 20 per month. And most states have the codes available for use, are turned on. And this may be obvious to people, but just doing that alone does not lead to implementation of SBIRT. It doesn't look like. The other thing to conclude from this is that incentive measure that went into effect sure did look like it correlated to that huge increase in use of codes. So when you create a statewide performance metric and you tie money to it, perhaps that's shown to be effective, at least in this case. And then the last thing we can conclude from this graph, I think, is obviously 99420, the screening-only code, gets used much, much, much more often than the brief intervention codes. And that's too bad because this isn't called S, it's called SBIRT. But apparently what this dramatic increase in Oregon is, it's a huge increase in screening, but really not so much in brief intervention or referral to treatment. But we don't really know because there's no codes to track referral to treatment. And as we've seen, the codes for brief intervention are so poorly suited for the qualities of primary care that they weren't going to get used even if they were done. Most brief interventions, I bet, are like 3 to 5 minutes. In fact, that's what we teach in our curriculum. Something that's realistic during patient visits. So we can't really say that brief interventions or referrals are not happening very much because, again, we're looking at what's documented, not what's actually happening. But it's troubling that what we've created here with this performance metric is a huge increase in screening, but much less so with brief intervention and referral to treatment. And I think that's due to the billing requirements. Another graph or table I wanted to show is even when you successfully document the encode and you submit it for payment, it doesn't always get accepted. Sometimes they're rejected, and it can be rejected for various reasons, like maybe the person who built that code wasn't an approved person to build that code, or it was a wrong kind of visit, the denominator. Anyway, I got these numbers from the state. And as you can see, for the screening-only code, the 99.20, about 75 to 80% of the time, it's increasing, which is good, where these codes actually accepted. So some concrete evidence that more SBIRT goes on is what is actually documented as tracked. And same for the brief intervention codes. Not all of them get accepted by the state. Here's another table, a little more complicated, but I want to report how well CCOs are doing. So on the left, the y-axis are the 16 CCOs, these are the Medicaid contractors. They're the ones ultimately held accountable for this. And they get the money from the state, and supposedly that trickles down to the clinics, that's between them and the clinics. And then the x-axis is the ratio, how the benchmark is 12 and 13%, as you can see in the red lines there in the middle. And the dots represent each year. So yellow is 2013, orange is 2014, brown is 2015. This is what they reported in the calendar year, that ratio. So one thing I noticed here is that almost all CCOs have improved each year, and that's great. Right now, in 2015, last year's data, there's 8 CCOs that have made the benchmark, and that's great. Even the ones that haven't, a lot of them have met their improvement targets, so they've improved enough over the previous year where they still get their money. So that's great. But again, we know that they've met these marks. They've met their incentive measure mostly because of screening. The brief intervention codes do not account for much of this. Another thing to be curious is, a policymaker or an expert advocate might think, well, I wonder why, these ones up here, Willamette Valley and Quad, I wonder what characteristics about them help them do this more often, achieve a higher rate than the ones at the bottom. And that's hard to measure because, well, I'll get to that second. First of all, statewide, just the numbers here, if you put all the CCOs together, these are the averages. So again, we're seeing improvements from everyone each year, and then this year they cross the 12% threshold, which is great. Also, the state reports data on race ethnicity, and I thought this was interesting. On one hand, it's reassuring because across races and ethnicities, with one exception, which I'll talk about, it's the same as the average. And I would expect that because we know, or you may know, that when clinicians are left to their own devices to figure out who they want to screen for alcohol and drug use and how to do it, biases come out. So physicians are less likely to do this with women, with Caucasians, with people from higher social economic status or background. But when you institute a workflow that's routine, that's universal, that it's just expected to happen with everyone based on their visit, I would expect those biases to go away. And since the Oregon Health Authority expects clinics to adopt this workflow, it looks like it has gone away with one exception, which is interesting. So Asian Americans are screened for alcohol and drug use less than other races and ethnicities in Oregon. And I had to look at the numbers to determine, the statistical significance of that. But just looking here at this graph, it sure seems like. So I'm surprised because, again, if you're doing SBIRT on a workflow, routine, standardized workflow basis, it seems like there's much less room for bias. But it looks like here that in Oregon we are doing this less. There's bias towards Asian American patients, and I'm not sure if the Oregon Health Authority has looked into that or if the CCOs or the clinics will look into that. But it appears that there may be some bias there. So back to the CCOs. These are the lowest performing CCOs based on last year, and I put this on a map to see maybe there's some correlation with where they're located. Because in Oregon, most of the people live here in the Willamette Valley, Eugene, Salem, Portland on the west side, and basically on this side, it's pretty rural. But the lowest performing CCOs, there's one over here, which is a higher density place in here. So I'm not sure if that really explains it. And then the highest performing CCOs, Josephine County it doesn't have a high density population base necessarily, or Douglas County, Willamette Valley does. So geographically, there doesn't seem to be much correlation here with performance. And then I kind of made this table just to show, how many members do these lowest and highest performing CCOs have? How big is their coverage area? How many members per square mile? But I don't really think it stands out there either. These numbers are pretty similar here on population density. I thought maybe it would be easier or harder to disseminate SBIRT to clinics based on how much territory you have to cover as a CCO. Because one CCO has almost all of Eastern Oregon. It's huge. It's bigger than a lot of states. That doesn't seem to necessarily explain it. And I like to show this slide because, when we try to figure out what characteristics can lead to sustainably integrating SBIRT into a clinic, we want to know that because that can be really helpful. But it's hard, and there's studies that examine the implementation science. But based on my own experience, and when I go around Oregon, I get asked to do trainings to clinics, the ones that I notice who successfully take this on, and the ones who don't. The ones who do, they have their leadership bought in. So meaning the medical director, the physicians have agreed to adopt SBIRT and to make it happen. And that's contrasted to clinics who say, yeah, we'll have an SBIRT training, thanks for coming in, and they send their nurses and their social workers and their MAs, and they have a nice little training, and then they go back and the physicians don't go to the training, and they don't know how to use these screening tools, they're not aware of the workflow, and it just kind of peters out after a couple of weeks. So you have to secure buy-in from the leaders first. You have to identify a workflow. A lot of people don't know that this really involves a new workflow that has not been in place before and now needs to be in place, and it's new, and that means training people on how to do their role. And if you have turnover, that means when new people are on board, they need to be trained. So not all clinics understand that. Training is not so hard. I notice clinics will make their MAs and nurses available pretty readily, at least for a 1 hour or 2 hour training, but this really takes a 3-hour training. If you want to train providers in a busy clinic how to do brief interventions, motivational interviewing is usually a new skill, primary care clinicians, and that takes practice. A didactic lecture is not going to ensure that physicians do brief interventions with any quality. And role-play practice takes time, and I say 3 hours minimum to do this, and that's hard. Clinics find it difficult to pull out their providers from the patient schedule for a 3-hour training, and this is why a lot of clinics don't do it. We need champions. We need inside people to advocate for this. We are going to document this in the EHR, so that means optimizing your electronic medical record to make sure that you can track this, and that means building new tools probably. How do you know when a patient's due for their annual screening? Well, you need to know when it was done the last time. Is that more than a year? Is that something your EHR can alert you to? Well, you'll need to build that tool. You probably need to build a tool that documents what happened, so your clinicians don't have to memorize all the appropriate language for the billing code. And this takes time and money usually to build these tools. And then we have pocket cards, reference sheets, patient handouts on our website that people can download, and I find that the clinics who actually use those tools, distribute them, are the ones who sustainably implement SBIRT. So this is not evidence-based here. This is my own opinion on the traits of clinics that do this or not. So we've seen how the ratio was created. We've seen the data now in Oregon of what's happened. So where are we today? Well, the finer points of billing are still being clarified. Little questions get asked, and sometimes they get answered, and sometimes the answer gets contradicted, and that's still ongoing. And a big bombshell was dropped last month when I heard inside information from the Oregon Health Authority that CPT code 99420, which we rely on to bill for screening, is going to be discontinued next year. CMS is no longer going to use that code. Why? I'm not sure. I think they're officially going to address this in the next. We have these monthly meetings in Oregon where we talk about our incentive metrics, so we'll get the full story then. But here we go. It's yet another drawback of using billing codes is they're outside our power or our control. And if some agency wants to change them, they change them, and then we have to deal with the after effects. So that'll be a little headache for clinics. So when they're getting used to using a code that they use often, they're going to now have to use a different code instead. Around Oregon, clinics are at different levels of doing this. You've seen the discrepancy in CTOs at a clinic level. Some people have already built better EMR tools. Some clinics are still trying to do this from a baseline of 0 with their own EHR. However, the Oregon Health Authority has said that they, in the future, will move beyond just billing codes, and they are going to allow clinics to submit electronic medical record reports on this. So they aren't going to go away from billing codes as far as they won't not allow them. They will allow clinics to submit this on a quarterly basis for their own EHR. When that happens, I don't know, 2 years, 3 years, they haven't said. But that's good to know that that's in the future. Now, EHR reports are not perfect themselves, obviously. You have to build tools to track this data yourself. We still don't have a way to track referrals to specialized treatment. We have no billing code for that, so we cannot know when that goes on. It's a serious drawback. Maybe that will change when the EHR reports happen in the future. And medication-assisted therapy would be nice to track. It's a very important part of helping some people who benefit from that, but that's also something you can't track. Maybe in the future that would be included. So, positive effects so far. To be fair, what Oregon has done, I think it's pretty significant. Yes, it's really only an increase in screening, but that's a huge deal. I mean, the baseline before 2013, like a lot of states, I think, was the huge majority of clinics in Oregon did not use any kind of validated screening tool or standardized workflow really to address alcohol drug use with patients. And now the huge majority of them do. And that was not an easy task, but a foundation has been laid, and that foundation has been laid because of the performance metric. It's the only reason it happened. Statewide Medicaid performance metric with money behind it is what made this workflow happen in clinics. So hopefully in the future, now that that foundation has been laid, maybe things can improve. We can figure out ways to track brief interventions and referrals to treatment. Maybe even in the future, and this is the most difficult part, would we be able to track the quality of a brief intervention? That's a serious detriment right now because there's no way, there's no requirement that makes clinics attend a certain length of training, or any training whatsoever. And we have no way to measure how good a brief intervention is. And it's my strong belief that there's a lot of poor quality brief interventions right now happening in Oregon because we have no system to measure how good they are. And because it's so difficult to train busy providers, I really doubt that they take the time on their own to learn how to do this. If you're familiar with MI, you know that it takes practice. And I'm just very skeptical that most providers are doing quality brief interventions. However, that said, even screening, there's some evidence that if you fill out 10 questions that are asked about your alcohol and drug use, that may have some effect on behavior. So we shouldn't discount too much the positive impact of, for the first time, screening tens of thousands of patients across Oregon for alcohol and drug use. CCO performance is improving. That's a great sign. This could have been much worse. It could have flatlined or not improved at all or gone down, but CCOs are improving. That's a sign that they are taking this on. Clinics get revenue now. The good point is, yes, the codes not always are accepted and have problems, but the codes that you do submit, you are most of the time getting money. And so that's great. Not only incentive money, hopefully that clinics get from their CCO if they meet the performance metric, but just the money from reimbursement for each visit. That's new, and that's a nice thing for clinics. And then by making this performance metric at a Medicaid level, it encourages commercial reimbursement. So I think the commercial payers are prodded now when they have these clinics routinely billing for us at the Medicaid level that they are supposed to reimburse for this too. Drawbacks, like I said, we are not really measuring brief interventions and referrals in the real world. The drawbacks for this is we don't know how often it's happening. I talked about the quality of intervention. It's probably poor. It would be great to require maybe providers to attend a 4-hour training and use standardized patients and measure the quality of the intervention. It's not really feasible, but without that, it's really hard to know. Another drawback of this is, when I showed that table of CCOs, there was one at the top there who was really performing at like a 23%. I forgot to mention how the drawback of this metric is it can be gamed. And I don't want to accuse explicitly anyone of gaming the system, but if a clinic decides to just skip that brief screen and just give the audit and the DAS to everyone once a year, and those are billable, it's going to be a lot easier to meet and exceed the benchmark than if you do the first step first. So if you just give everyone an audit and DAS once a year, it's like 10 questions each, you can bill for those. And if you bill for those, once a year, the benchmark of 13% really doesn't apply. At that level, the benchmark should be like 80% or something. We can't really tell clinics what to do. The Oregon Health Authority really poo-poos that, and I don't know how pervasive it is. From a medical standpoint, you can't really say that's wrong. It does put some more burden on a patient to answer unnecessary questions for most of them. You really should start with a brief screen first and then go to a full screen. But, clinics can do that. And if they do that, then they have an unfair advantage over other clinics. So like a lot of metrics, sometimes there's ways, unfortunately, to game the system. And then, of course, documentation burden. We should not underestimate the burden we put on primary care people when we want them to do something, because if they need to document it, that's a big deal. The documentation burden is already huge, and it's just growing. Every once in a while, a primary care clinician confides in me after a training that, there's a lot of times where they were thinking of going on to a different line of work because I spend so many hours each day just charting and checking boxes for things we're supposed to do, and it just doesn't feel related to patient care. So that's a big deal. And then, ironically, sometimes when we do a metric, it can kind of steer clinicians away from patient care, because if you're supposed to check a box or you're supposed to document something in a certain way, it may not be necessarily what the patient needs in that scenario. We all respect clinician judgment, right? It's the judgment in that patient that rules overall. But if you're trying to meet performance metrics, it may not be what's needed in that moment, and we're kind of keeping away from the clinician. Lessons learned. I think these main 3 lessons learned based on my experience. So obviously, if you're going to create a performance metric, consider alternatives and benefits from what you're seeing. And please consider the impact you have on medical settings when you create performance metrics, because often people on these committees create metrics are not necessarily practicing clinicians. Practicing clinicians don't necessarily have the time to sit on these committees and create these metrics. The problem is that means you're kind of unattached to the real world realities of what you're doing and its impact on care. You should try to run by these metrics, try to include as much as you can in practicing clinicians on your committee. And then it will be likely that when you put a performance metric into place, you will learn, and you get feedback from clinics, that certain things need tweaking, certain rules need clarification, and try to establish a clear communication channel to convey that. If you just update a web page on a site that never gets looked at, it's not really fair. Reach out to people, other SBIRT advocates who may not be part of the performance metric, who may have people that are aligned with you, and make sure they are aware of these changes, because that will just create a kind of a cynical attitude from a lot of clinics when you just hear after the fact of all these little tweaks, and it makes a big impact on their EHR, and it wasn't communicated on a timely basis. So have something in place where that gets communicated well. Questions to consider. This is the last slide here. And I don't have answers. Should the health authority have used EHR reports from the beginning? Perhaps. But on the other hand, maybe that would have been more of a slow start, because clinics would have to build tools to capture that information. I don't know. No evaluation method is perfect. Should SBIRT training be required? So in Washington State, I know that anyone who wants to bill for SBIRT has to attend a 4-hour online training. That kind of makes sense. That's one way to ensure to some degree that there's some fidelity to the model before someone bills for this. On the other hand, it's not too feasible to ask providers to attend a 4-hour training. It doesn't do a great job, but it's something to consider. I mean, if we're expecting clinicians to do this, should we also require or expect them to do training rather than just leave it up to them? And then ultimately, back to this whole Oregon Medicaid reform effort, the whole purpose of this SBIRT incentive measure, along with the 16 other incentive measures, is to bend the cost curve. The whole idea of why we're doing this, at least from a Medicaid perspective, is can these lead to patient outcomes, which will lead to less healthcare costs. And that means basically less healthcare utilization, less trips to the ER, less hospitalizations, perhaps even less trips to primary care. And, you know, I'm skeptical because right now all we've done is really increase screening as far as we know, and I don't know if that's really contributing to bending the cost curve. So we have to show CMS as part of our waiver that we got that we are bending the cost curve. And I'm not sure when we need to show that and to what degree, but I'm not so sure SBIRT is going to contribute to that much at this point. Maybe it will in the future. So I want to leave a few minutes for questions. Thank you for your time. I know that was kind of detailed and we got into the weeds, but I hope this information was helpful.
All right, thank you, Jim, so much. We did have a couple questions come in, so I will go through them now. The first one says, Jim, can you please explain, with the exception of SBIRT, how does the 17 measures differ from those for PQRS and meaningful use?
That's a good question. I can't say that I know, because how these, I'm going to go back to the slide here so you can see what those measures are. So how these measures, if they're different than other performance measures, I don't know. I think if you Google CCO incentive measures Oregon, each one is listed and they say where it came from. And some of them came from what the questionnaire said, and others don't. But I can't tell you why these certain ones were picked. But if you want to know the details, it is on the Oregon website.
Okay, perfect. Thank you. The next question is there a reason as to why ICD-9 codes are still being utilized as opposed to the ICD-10?
No, I don't know if they are. And as far as I know, as of October of last year, everyone is supposed to use ICD-10 codes, and that's what's expected in Oregon as far as the incentive measure. So I don't know why ICD-9 codes will still be used, because I don't think they're accepted.
Okay, and there's 3 more questions. The next one is SBIRT mandated in Oregon?
Well, that's kind of tricky because it's called an incentive measure, and that means 3% of the total budget of each CCO is withheld unless they show they're meeting these incentive measures, and if they do, then all the money is given to them, which can mean millions of dollars for some of the larger CCOs. Now, is that a mandate? Not technically, because it's a money-based measure, but you know, it's kind of expected is the way I would describe it, that clinics have to do this. Some clinics I know have not yet done a SBIRT. I don't think they're getting punished, but their CCO can be losing money if clinics don't do this. So technically it's an incentive measure, not a mandatory measure.
Okay. The next question is, New Mexico currently has a SAMHSA SBIRT grant, and the New Mexico SBIRT model includes a counselor and peer support worker assigned to a medical site. The New Mexico model also includes brief treatment up to 12 sessions by SBIRT counselors on site. Has Oregon considered brief treatment as a source of revenue, and is there data on this to your knowledge?
That's a good question. You know, brief treatment, for those folks who don't know, is what's called when maybe a patient who would benefit from a referral to specialized treatment is not ready to go or can't go, and maybe they are willing to continue to come back to your clinic and see your social worker or counselor or someone who's trained in brief treatment, which means like delivering cognitive behavioral therapy or something other evidence-based. And that's an opportunity to take advantage of. It's called brief treatment. So if someone can come back and see you at your clinic for that, that's better than nothing at all, even though it may not be as beneficial as specialized treatment. So that's great if you do it now. It's not part of the measure in Oregon, probably because there's no specific code for it. However, you would be able to bill a brief intervention code for that. So if you talk about behavior change with a patient who has unhealthy alcohol or drug use and you spend at least 15 minutes doing it, which I'm sure brief treatment does, then you can build those brief intervention codes. But technically, the Oregon Health Authority has not recognized brief treatment as a separate entity from a brief intervention.
Okay, great. I want to thank you all for your questions, and thank you again, Jim, for such a great webinar. At this time, I would like to go over our evaluation and CEU instructions. You will receive a few emails from us following the webinar. In the emails will be a link to the recording of the webinar as well as a PDF version of Jim's slides. Also included in the email is a link to the evaluation. Our grant evaluators are required employees to collect feedback from all event participants. Completion of this evaluation is critical to maintain our funding and continuing to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for a certificate of attendance or NADAC and PCB CEUs. Should you choose to skip the evaluation and proceed directly to the CEU request, leave all the answers blank on the evaluation. Again, we want to thank you for your participation today, and if you have any questions, please email us at info@ireta.org. Thanks, everyone.